net reabsorption of the solute is happening in the tubules, primarily proximal tubule. Anyway, we'll see that. Dehydration increases plasma concentration of all except atrial natriuretic peptide. Option D is the right answer. Question 8. Which would not be expected to increase in renin secretion? The right answer is option C, administration of a drug that blocks beta-adrenergic receptors. Question 8, option C. Question 9, the graph, what solute it is? You got to identify the solute, it's going to be sodium. Question 10, right? There is a condition where there is elevated aldosterone and decreased renin. And what diagnosis is this? How are you going to proceed on with the case? The answer is hypokalemia. Question 11, a nurse in a pulmonology clinic administered spirometry test. It's a normal value 5 liters. What statement describes the volume or capacity the nurse measured? Right answer is C, amount of air expired after maximal expiratory effort. 12th question, premature baby delivered and surfactants. What is the role of surfactants? It helps prevent alveolar collapse during breathing. A is the right answer. For question 13, pulmonary fibrosis. What's the right answer? Low FEV1, low lung compliance. Question 13. Question 14, which of the following would be consistent with diagnosis of asthma, obstructive lung disorder? Right answer is D, right? Low FEV1, low FEC, low ratio before the inhalation of the drug, and after inhalation, there is going to be improvement in all the parameters. Question 15, poorest ability to hold on to oxygen, whole blood which has got no hemoglobin. Option B is the right answer. Question 16, a student brought into the campus after a bout of vomiting, dizziness, numbness in extremities. There is increased bicarbonate and elevated pH as well. The answer is metabolic alkalosis. Question 17, carbon monoxide. How does it affect oxygen transport? It competes with oxygen for hemoglobin, resulting in anemic hypoxia. C is the right answer, doctors. Question 17. Question 18. If there is a block in pulmonary blood flow, what will happen? It will lead to a dead space, and dead space ventilation perfusion ratio is going to be 0, right? So which of the following occurs if blood flow to the alveolar unit and region of perfusion defect is totally obstructed by a pulmonary embolism, right? So again, the PO2 of alveoli affected by embolism will be equal to PO2 in inspired. Yeah, that's wrong, doctors. B is wrong answer. It's the right answer is option D. Please make a change of it. The right answer is option D here. B/Q ratio, it's going to be 0. And then identify the condition indicated by question mark in the graph. It's going to be restrictive lung disease, which is nothing but surfactant deficiency. Bronchial asthma, old age, emphysema do have increased compliance, whereas surfactant deficiency will have decreased compliance. So for this graph, the answer is going to be surfactant deficiency. And question 20. The right answer is going to be the graph B. All right, PaO2 of a subject has changed from normal value 50 millimeters of mercury. The respiratory response curve for CO2 will be shifted to B. B is the right answer, doctors. For question 21, it's sinoatrial node, where there is going to be slowly depolarizing prepotential. The answer is SA node. Question 22, ventricular rate is lower than atrial rate, right? There is a second degree AV block. Obviously, ventricular rate is going to be lesser than atrial rate. For question 23, which channel contributes to rapid depolarization? Sodium channels. Option A. Fourth heart sound, when is it heard? Option C, ventricular filling is the right answer. Question 25, 75-year-old woman, history of chronic congestive failure, where there is going to be peak left ventricular systolic pressure. At what phase of cardiac cycle the LV systolic pressure peaks? It's going to be ventricular ejection, C. Question 26, what happens if a patient's heart rate was 66 and it is increased to 175 beats per minute? There is a significant tachycardia. How does the timing of cardiac cycle gets adjusted? There is going to be a drop in systolic time as well as diastolic time. Option D is the right answer. For question 26, option D is the right answer. 27, 53-year-old woman, chronic lung disease and everything. What are the stimulus for peripheral chemoreceptors and central chemoreceptors? Option C is the right answer. Peripheral chemoreceptors are sensitive to PaO2, whereas central chemoreceptors are sensitive to carbon dioxide levels. Question 28. There is going to be an administration of drug losartan. That's an angiotensin receptor blocker. What's going to be the change in blood pressure, renin, and aldosterone? Drop in blood pressure, drop in renin, increase to renin, drop in aldosterone. Question 28, D is the right answer. Question 29, 45-year-old woman comes to her family physician, yearly checkup. BP is going to be same while lying as well as standing. What changes in heart rate, preload, and pulse pressure most likely to occur in going from lying to standing position? B is the right answer. Heart rate increases, preload decrease, pulse pressure decrease, doctor. So that's question 29 and then question 30. Following a motor vehicle accident, what's going to happen? There is a hemorrhage and there is a shock onset. And what are all the possibilities that worsens the shock? Option A, increase in core body temperature is the right answer. So that's the first 30 questions, and we are going to address the first 30 questions, and we'll be taking up a break, and we'll come back to the next 30 questions in the second session, after a small break, guys. So without much delay, we'll start on our discussion. So guys, let's take up our first question here. So let me just turn on all these mobile in silent mode. Yeah. Fine. So the first question, pH of a solution is defined by the ratio of conjugate base to the acid content of the solution. The expression is, it's Henderson-Hasselbalch equation, doctors. The answer is Henderson-Hasselbalch equation. Fick's law indicates simple diffusion. Fick's law governs simple diffusion. Gibbs-Donan effect is an effect that says why there is going to be increased potassium inside the cells. Why more potassium is present inside the cell, and why there is going to be more anionic charges inside the cell. So intracellular fluid is primarily anionic in charge, and the most dominant cation in the ICF is going to be potassium. These two factors are explained by Gibbs-Donan effect. Fick's law explains simple diffusion. And obviously, Henderson-Hasselbalch equation is the one that is going to determine pH of a solution. So when it comes to calculating pH of a solution, we are going to use different parameters, pKa and logarithm of anions, that is conjugate base by logarithm of acids as such. All right. So this relationship that is involved in determining pH of a solution is explained by Henderson-Hasselbalch equation, doctors. That's first question. I repeat, Fick's law for simple diffusion, Henderson-Hasselbalch equation for pH calculation. Gibbs-Donan effect explains why there is going to be more potassium inside the cell. Potassium is an intracellular cation, isn't it? Why is that so? That's Gibbs-Donan effect. I hope question A is a straightforward one, not much of complication. That's question 1. Moving on to question 2. Calculate the osmolality of a given sample of blood with sodium levels given 145 milliequivalents, glucose level given 100 milligram, blood urea nitrogen is given 1 milligram per deciliter. How are you going to calculate osmolality? Now, doctors, in a very simple term, osmolality can be calculated using a simple formula. It's going to be 2 into sodium levels. That is a very simple formula with which you can able to calculate osmolality. In case, if potassium is also given, please go for 2 into the values of sodium plus the values of potassium. If you have potassium level given in the question, you got to use a different formula, and that's going to be sodium as well as potassium. Now, we have a doubt here from the previous question. Gibbs-Donan effect is not for RML, resting membrane potential, doctors. Is that what are you mentioning, Dr. Ruchi? Or is that RMP or RML? Resting membrane potential, or what is RML? Yeah, RMP. No, doctor. Gibbs-Donan equation is not for RMP. RMP is measured by Boltzmann equation. Dr. Ruchi, please be clear. Resting membrane potential can be calculated by Boltzmann equation or Hodgkin-Huxley equation. All right, not Gibbs-Donan. Please remember that. So, yeah, let me be clarifying that question as well. So when it comes to calculating resting membrane potential, RMP is calculated using two equations. Number one, Boltzmann equation. If not Boltzmann equation, the second one is going to be Hodgkin-Huxley equation. So these two equations are for resting membrane potential, whereas Gibbs-Donan effect explains why there is more potassium inside the cell. All right, it's a simple expression here when it comes to Gibbs-Donan effect. Please be aware of this as well. Gibbs-Donan effect. We're going to have a cell here, and this cell naturally is going to have proteins inside, right? The cell is naturally going to have protein inside on this. No, Nernst one is not for RMP, I'll tell you that. Now, inside the cell, cytoplasm has got more amount of proteins. These proteins carries net negative charge. There is going to be tremendous amount of anionic charges inside the cell. The proteins are non-diffusible, right? Which means we don't see the proteins moving in and out of the cell. It's more or less static. Since the proteins are very static, they exert a tremendous amount of anionic forces inside the cell. That anionic force will try to attract cations. The anionic forces will try to attract cations. At the same time, these anionic forces will try to repel anions. All right, the net anionic charge inside the cell. Please remember, the net anionic charge inside the cell attracts cation and repel anion. When it comes to cations, what are the possible cations we could be able to see? Sodium can be attracted, potassium can be attracted, calcium can be attracted. Primarily, sodium, potassium, and calcium. Of course, there are magnesium, manganese, but the concentration of magnesium and manganese are not so vast. As a consequence, we can practically ignore magnesium, manganese, zinc, selenium, and everything. So the primary cations are going to be sodium, potassium, and calcium. But the point here is, when it comes to sodium as well as calcium, sodium and calcium travel via gated channels. If you could be able to remember, sodium as well as calcium gets into the cell through voltage gated channels. There are separate voltage gated channels for sodium, separate voltage gated channels for calcium. Sodium, of course, can also move through ligand gated channels. But if you consider these three ions, sodium, potassium, and calcium, when they are getting attracted by the anions inside the cell, sodium and calcium cannot be able to subjugate themselves to the attraction force, because even though they try to move in, the gated channels will not let sodium and calcium to move, because the gates do not open without a trigger. Without an appropriate stimulus, the gate does not open. Whereas, if you consider potassium, potassium is an ion that travels via leaky channels. Potassium is an ion that travels via leaky channels. As a consequence, subjugating to the attraction force, potassium moves inside the cell and huge amount of potassium gets deposited in the cytoplasm. This is what is going to contribute enormous amount of potassium inside the cell. 150 milliequivalents per liter of potassium is seen in the cytoplasm, whereas extracellular fluid potassium is 3.5 to 5.3 milliequivalents, isn't it? This effect, where the cations in the form of potassium are attracted by anions inside the cell, leading to uneven distribution of potassium ions. If you could see the potassium concentration, you can clearly understand the ICF concentration of potassium is 150 milliequivalents. On the contrary, when it comes to the ECF concentration, all right, the extracellular fluid concentration of potassium is going to be 3.5 to 5.3 milliequivalents. There is going to be a huge disparity. This disparity of potassium ion distribution, this uneven distribution of an ion is seen, and the reason for this uneven distribution is going to be the proteins, doctors. It is the proteins that causes uneven distribution of an ion. And this effect executed by proteins over potassium is an effect called as Gibbs-Donan effect. Please understand this. And it's a kind of a frequently asked question. All right. So that's Gibbs-Donan effect. I hope you could be able to understand this now. Gibbs-Donan effect. And when it comes to resting membrane potential, as I just told you, you have two equations. One is Goldman equation and the second one is Hodgkin-Huxley equation used to determine resting membrane potential. And since you came up with the next question, the next potential, right? Nernst potential. Let's also get to see what a Nernst potential is all about. That's Gibbs-Donan effect. And let me move on to Nernst potential here. Nernst potential is used to decide membrane potential when an ion is not moving. Please remember, this is not resting membrane potential. Let me take up a cell, and in the cell membrane, I'm going to take up two channels, two potassium channels, all right? You guys know this is a leaky potassium channel. So let me take up two leaky potassium channels. You know the concentration gradient, isn't it? You know the concentration gradient for potassium. Inside the cell, it is going to be 150 milliequivalents. Outside the cell, 3.5 milliequivalents. So this concentration gradient will drive the potassium to move out of the cell across the channel. So potassium moves out of the cell across the channel due to concentration gradient. You guys also know extracellular fluid has got tremendous amount of sodium in the concentration of on an average of 145 milliequivalents. So this enormous amount of sodium will try to repel the incoming potassium. Please remember, potassium is a cation, sodium is also a cation. So when potassium leaks out of the cell due to concentration gradient, it will be repelled by sodium due to electrical gradient. And as a consequence of electrical gradient, the same potassium ion will get back into the cell due to electrical gradient. So two forces are acting here. Two forces. Number one, it is going to be concentration gradient. Number two, electrical gradient. As a consequence, there is going to be continuous influx and efflux of potassium. Potassium ion get out of the cell due to concentration gradient, get back into the cell due to electrical gradient. As a consequence, there is a net consistent flow of this cation. Now, what you do in this cell, you are going to try an experiment. Please remember, Nernst potential has got no clinical applications. Nernst potential has got no real-life applications. It's a mere experiment. What are you doing? You're going to equate, you're going to balance concentration gradient. And you're going to equalize the concentration gradient with electrical gradient. When these two forces are getting balanced out and getting equalized out, please remember, now we are equalizing both the forces. What this will do to the ion, this will stop movement of the ion. So there is going to be no net movement. There is going to be no net movement of ions. When the movement of ions are getting stopped, you have practically stopped electricity because you know basic current, right? Current is nothing but movement of charges. When you stop the movement of potassium ion, you're creating an environment where the contribution of potassium to the current is being taken off. It's being nullified. As a consequence, the potential of the cell is being vastly changed. So that potential of a cell, when you record, if you stop movement of one particular ion, is going to be Nernst potential of that ion for that cell. So doctors, please remember, Nernst potential is not for RMP calculation. It is an experimental situation where we actually stop movement of one ion and we measure the potential inside the cell. So if you do this for the same cell, doctors remember this, for a same cell, the Nernst potential of potassium is going to be minus 96 millivolt. Nernst potential of sodium is going to be plus 66 millivolt. For chloride is going to be minus 70 millivolt. For calcium, it's going to be plus 130 millivolt. So these are all different potentials you can able to record from the cell when you stop movement of potassium or sodium or chloride or calcium. All right. So remember, Nernst potential is also called as isoelectric potential. What do you mean by isoelectric potential? It means you have practically stopped movement of charges. It is an isoelectric state. It is an isoelectric state. Since you have equalized both the forces, this can be also called as equilibrium potential. This can be also called as equilibrium potential, doctors. So, guys, the first question, it's a question which uses a lot of laws. All right, you must be familiar with Fick's law, Gibbs-Donan effect, Nernst potential, Goldman equation, Hodgkin-Huxley equation. All right. So I hope you all are clear and thorough with the question 1. I hope so. And I hope there is no doubt in question 1 as well. Dr. Ruchi, I think you got your answer cleared. Am I right? There is no doubt, I believe so. So, yeah. Perfect. Now let's move on to the second question. How are you going to calculate osmolality? It's a simple calculation-based question. So you can use different formulas, all right? If you got only the value of sodium, go for first formula 2 into sodium level. If you got sodium level as well as potassium level, go for second formula, sodium plus potassium. Third formula, 2 into levels of sodium, 2 into sodium level, plus 0.055. 0.055 into values of glucose plus 0.36 into values of blood urea nitrogen. So to calculate osmolality, you have 3 different formulas. You can use any of the formula that can be, given in the question based on the variables that is given in the question. But anyway, guys, the time-saving method is step 1. All right, time-saving method is formula 1. 2 into sodium levels. So unless otherwise you have values given in very, very close numbers, say for example, 290, 298, 300, like this. When you have answers which are very, very closely placed, you can go for this, variations in the formula. You can try the appropriate formulas if the options are given in a very close values. But if you see options which are widely placed, it's better to use the simplest formula. So it's going to be 2 into sodium level, and that will give me, it is 145, isn't it? So 2 into sodium level will give me 290 milliosmoles per kilogram water, and hence option A is the right answer for this question. All right. So just be aware of these 3 formulas: sodium, sodium plus potassium, sodium, glucose, as well as blood urea nitrogen. Right. That's question number 2. Coming to question number 3. Calculating effective renal plasma flow with following variables. It's a question on clearance. So we are actually calculating clearance of para-aminohippuric acid. This includes urine concentration of para-aminohippuric acid multiplied by urine flow rate. Concentration has to be represented in milligram per ml. Flow rate has to be represented by ml per minute. And we have to divide this by plasma concentration. Plasma concentration, doctors, and the formula is going to be U V by P. That's the formula, right? So if you substitute these values, you're going to get 14 multiplied by 1 divided by 0.02 milligram per ml, 0.02 milligram per ml. Converting everything into whole values, it is going to be 14 by 0.02. That's nothing but 1400 divided by 2. I'm multiplying both the numerator and denominator by 100. All right. So it's going to be 1400 by 2, and answer is going to be 700 ml per minute. So that's the right answer for question number 3. Calculate effective renal plasma flow for the given variables, isn't it? All right, people, I hope you're being clear with this question as well. It's 700 ml per minute. Fine. Moving on to question number 4. Tubuloglomerular feedback operates with a purpose. Option A, maintaining glomerular filtration rate in accordance with renal plasma flow. That is a very wrong statement. All right. In case if you consider GFR, tubuloglomerular feedback is used to maintain more or less constant GFR. More or less constant GFR. When I say constant GFR, you have to understand, in spite of increase in renal plasma flow, or there can be a drop in renal plasma flow, the GFR has to be maintained constant, and that is one of a key role played by tubuloglomerular feedback. We call this as autoregulation of GFR. In this autoregulation of GFR, tubuloglomerular feedback is one of the important mechanism with which it's getting operated. So it is a constant GFR, not in accordance with renal plasma flow. So option A is wrong. Option B, renal arterial pressure. Renal arterial pressure as well as renal arterial volume, both are getting maintained by renin-angiotensin mechanism. Both are getting maintained by renin-angiotensin system. Even if you consider this in the anatomical terminology, you can think of juxtaglomerular apparatus, but not tubuloglomerular feedback, right? So again, maintaining of renal arterial pressure and volume involves juxtaglomerular apparatus, not tubuloglomerular feedback. Again, option B is wrong. So option C, maintaining constancy of load delivered to distal tubules. Let's keep this in open. Option D, maintaining constancy of sodium absorption in proximal tubule. Again, that is wrong, people, because maintaining of constancy of sodium absorption in proximal tubule is maintained by glomerulotubular balance. Glomerulotubular balance, doctors. So again, that is not going to be involving tubuloglomerular feedback, and hence, by exclusion, option C is going to be the right answer, maintaining constancy of load delivered to distal tubules, right? So tubuloglomerular feedback operates. The best answer for this question among the options given, I'm not saying this is the best answer. I'm saying among the 4 options given, this is the best option, because definitely A, B, and D are wrong, and hence we are going with option C as the best answer, doctors. That's question number 4. Coming to question number 5. The greatest fraction of filtered sodium is reabsorbed in what portion of nephron? It's a simple question. It's going to be proximal tubule. Proximal tubule reabsorbs 60% of sodium. Loop of Henle reabsorbs 20% of sodium. Distal tubule on an average of 5%. Collecting duct on an average of 5%. So the major site of reabsorption of sodium is going to be proximal tubule, and hence option A is the right answer, doctors. Coming to question number 6. If the clearance of a substance that is freely filtered is less than that of inulin, what happens? There is going to be net reabsorption of substance in the tubule. I hope you get this point. Now, inulin clearance will give us the rough estimate of glomerular filtration rate, and that's going to be 125 ml per minute. 125 ml per minute. So, inulin is a substance which is neither getting secreted in tubules nor getting reabsorbed in tubules. Inulin is a substance which is getting only filtered in glomerulus. There is going to be filtration alone. There is going to be filtration alone. There is no secretion, no reabsorption. All right. That's just a filtration. Since another substance is being used, and this substance is also freely filtered, but on another condition, this is getting lesser values of GFR than inulin. So what does that mean? It's getting freely filtered, no doubt about it. But along with filtration, it is also getting reabsorbed. Just because it also gets reabsorbed in the tubules, the net value in the urine decreases. And as a consequence, you are going to get a lesser value, and hence this substance is getting reabsorbed. This substance is getting reabsorbed. If it is getting secreted, you're going to experience increase in clearance. If it is getting secreted, it is going to be increased clearance. Neither secreted nor reabsorbed, it is going to be equal to clearance of inulin. equal to clearance of inulin. The substance become bound to proteins in the tubule. Again, this is not at all possible because proteins are not going to get filtered out. So the best answer for this question is option A, right? So we got a doubt here. We'll address that as well. Free water clearance. All right. Free water clearance is a condition. Let me, take a new space here. Yeah. Now to remember this, when it comes to free water clearance, it tells us that how much of water is getting excreted. Let me be clear, how much of water alone is getting filtered in glomerulus. And as a consequence of filtration, how much of water is getting excreted in urine. Is getting excreted in urine. This terminology is what is called as free water clearance, which means in an example, consider this as a blood. All right. Now, there is a subject, for example, I'm saying doctors, who has got simply 4 ml of plasma. The whole blood volume in a subject is just simply 4 ml. Out of this 4 ml, each ml has got some X amount of water. Each ml of plasma has got some X amount of water. Now, free water clearance is how much ml of plasma is completely cleared of water. So in this example, if the blood circulates into the kidney for one time, 1 ml of plasma is getting cleared of water. So the volume of water that is completely clear, volume of plasma that is completely clear of water is called as free water clearance. Now, free water clearance is expressed in a ratio. We are going to compare normal excretion with free water clearance. So we take value 1 that says optimal excretion of water. We got a value 1 that says optimal excretion of water, that says normal 125 ml per minute of plasma is being cleared of water table, right? That's free water clearance terms. If this value becomes more and more and more higher, if the value becomes more than 1, what does this tells you? Now this plasma is losing, more amount of plasma is losing water. So increased values of free water clearance says that there is going to be more excretion of water. There is going to be more excretion of water, which means more ml of plasma is being cleared of water. Values less than 1 is going to tell you under excretion of water. Under excretion of water, doctors, right? So free water clearance indicates how much of water alone is being taken out of plasma. It does not include any solutes, sodium, glucose, chloride, nothing, just water alone, right? We are going to express the water excretion in a ratio with relationship to the normal value, right? A constant value, normal value. And we see the value getting closer to value 1 if the excretion of water is optimal or normal. If the value increases, it means the subject is excreting more water. If the value of free water clearance is getting lesser and lesser, it means the subject is excreting lesser water. So that's the way with which free water clearance has to be understood. And this free water clearance has got nothing to do with GFR, people. Please remember, whenever we use inulin, we are talking about measurement of glomerular filtration rate. So clearance can be used to measure 2 parameters. And please remember, when we use clearance of inulin, clearance of creatinine, we mean to say we are actually measuring glomerular filtration rate. And if we measure clearance of para-aminohippuric acid, we are referring to measurement of effective renal plasma flow. So remember this, if a substance is going to be renal plasma flow, no, Dr. Mohammed, it is not just renal plasma flow, it is effective renal plasma flow. There is a subtle difference there, please be aware. Effective renal plasma flow, I'll be clear here. It's going to be effective renal plasma flow. is something that can be measured by clearance, and the value is going to be on an average of 625 ml per minute. 625 ml per minute. Effective renal plasma flow tells us the amount of plasma which is being filtered in the glomerulus, all right? Amount of plasma that is being filtered in the glomerulus, that is going to give us the content. So para-aminohippuric acid is going to be present in the plasma, and this para-aminohippuric acid is going to be filtered in the glomerulus. To some extent, it will be secreted in the tubules as well. So what are we actually measuring here? We are straight away measuring para-aminohippuric acid, and we are indirectly estimating it as a value for plasma flow. But are we straight away measuring plasma? No. So here plasma value or plasma measurement is a hidden parameter, is an indirect parameter. The direct one we are actually measuring is para-aminohippuric acid. So we are going to get a value which will be slightly lesser than the actual value. And this lesser value than the original actual value is what is called as effective renal plasma flow. It is effective renal plasma flow because you're actually measuring para-aminohippuric acid and not the plasma straight away. But if you use other method and if you go for plasma measurement, we call this as actual renal plasma flow, and the value of actual renal plasma flow is going to be 700 ml per minute. So please remember, if your question does not say the word effective, you can't think it as a complete volume. You have to make sure what your question is meaning. So how are you going to pick the clue from your question? Look at these words. Either your question has to use the word effective or your question has to use the word para-aminohippuric acid. If you see these two words in your question, you got to pick 625 ml as the answer. If you don't see these two words and your question is giving you actual renal plasma flow, you got to use the number 700 ml per minute. So that's a subtle difference, doctors. All right, please be aware of the difference. All right. So I hope Dr. Sahil and Dr. Mohammed, I think your concept of free water clearance and renal plasma flow is clear. Yeah, that's good. Now we'll move on to the next question. Good. We'll move on to the next question, doctor. Dehydration increases plasma concentration of all the hormones except. It's simple. When it comes to dehydration, the patient is going to have a decreased plasma volume. There is going to be reduction in plasma volume because there is going to be loss of water. At the same time, there is going to be increase in plasma osmolality. This decreased plasma volume and increased plasma osmolality, they go and trigger hypothalamus, thirst centers of hypothalamus. When thirst centers of hypothalamus are getting activated, there is going to be production of antidiuretic hormone, that is vasopressin. So dehydration increases the plasma concentration of all. Definitely the value of vasopressin is getting increased, no doubt about it. With dehydration and decreased plasma volume, there is going to be a corresponding drop in blood pressure, and this drop in blood pressure is going to trigger renin. With triggering of renin, there is going to be a increased synthesis of angiotensin 2, and this increased synthesis of angiotensin 2 increases aldosterone as well. You guys know very well the trigger for aldosterone synthesis is angiotensin 2. So vasopressin level is increased, renin level is increased, angiotensin level is increased, aldosterone level is increased. So what cannot be increased under this circumstance? It is going to be atrial natriuretic peptide, and hence A and P is the right answer. When does atrial natriuretic peptide is getting released? Whenever there is going to be increased right atrial volume. Whenever there is going to be increased right atrial blood volume, now this increased right atrial blood volume is going to increase the synthesis of atrial natriuretic peptide. This leads to excretion of more sodium and excretion of more water. So a patient under dehydration can't afford to synthesize atrial natriuretic peptide because that will dehydrate the patient even further. So everything will be increased except the answer is going to be atrial natriuretic peptide. That's question number 7. Question number 8. Which of the following would not be expected to increase renin secretion? Best answer is administration of a drug that blocks beta-adrenergic receptors. Why? We have a cell called as granular cell in afferent arterioles. These granular cells are also called as juxtaglomerular cells. Granular cells, which are also called as juxtaglomerular cells, it is this juxtaglomerular cells that produces renin. The granular cells are getting activated by sympathetics through the neurotransmitter norepinephrine, along with sympathetics triggering granular cells. These granular cells are also being triggered by catecholamines, circulating catecholamines. That includes epinephrine or adrenaline, noradrenaline as well. All right, people. The activation is through beta-1 adrenergic receptors. The activation is through beta-1 adrenergic receptors, and this beta-1 adrenergic receptors are located on granular cell, which is why there is going to be synthesis of renin. So if you add a drug that blocks beta-1 adrenergic receptor, we are going to see a drop in renin secretion that is nothing but not be expected to increase. It's a very simple question actually, drop in renin, right? But they have framed it in a kind of a jargonistic manner, not to be increased. So option C is the right answer for this question, doctors, right? So answer for this question was wrong in quiz. All right, but at least you know what is the right answer now, right, doctor? Yeah, I'm sorry for the quiz part, but this is the right question. This is the right answer. All right. Yeah. So that's question number 8. Coming to question number 9. The graph given below represents relationship between concentration of solutes in tubule fluid as a function of length along the proximal tubule. TF is the concentration of the substance in the tubular fluid. P is the concentration of substance in plasma. Identify the solute indicated by. Now you can clearly see the x-axis tells you percentage of distance along the proximal tubule. So on the x-axis, we are actually measuring proximal tubule, doctors. We are measuring proximal tubule on x-axis. What are all getting absorbed? What are all not getting absorbed? That's the fundamental idea behind the question. Now you are seeing a content whose concentration is getting maintained, right? So we are seeing a content whose concentration is unchanged. What can lead to a fixed concentration? What can lead to concentration of a substance that remains same, which is neither getting increased or decreased? Concentration is all about volume or value of the substance or amount of the substance in blood, all right? Amount of the substance in blood, some ml or something. So if there is going to be an equal amount of reabsorption, if there is an equal amount of reabsorption of water and solutes, if water as well as the solutes are equally getting reabsorbed, there is no difference. If there is 60% of water reabsorption, 60% of that particular solute is also getting reabsorbed. When the movement of water and the particular solute is parallel in the same quantity, the net concentration of the solute is going to be just the same, and the concentration remains static and ideal. Concentration remains static and ideal, doctors. So that is the red color line explaining us. So what ion can be reabsorbed in the same quantity just like water? It's going to be sodium. So in proximal convoluted tubule, if you consider, there is going to be reabsorption of 60% of filtered sodium, 60% of filtered water, 60% of filtered potassium. All right. Sodium, water, and potassium are reabsorbed up to 60%. when it comes to chloride is going to be on an average of 60%, but not exactly 60%, whereas glucose as well as amino acids. Glucose and amino acids are reabsorbed 100%, 100% of glucose and amino acids will be reabsorbed. So how does the curve for glucose will be, amino acids will be? By the time they reach 100% of proximal tubule, the concentration will become absolutely zero. The concentration will become zero. This is how the curve for glucose will be seen. The curve for amino acids will be seen, right? Bicarbonate is also getting reabsorbed to a value of about 95% or 90%. So this is again is going to have a very lesser concentration curve, people. So by any definition, you are going to see the value of sodium not getting changed in proximal convoluted tubule. The concentration remains same because it is going to be an equal reabsorption of sodium as well as water. All right, doctors? Fine. No. Blue, the point is, Dr. Ruchi can clearly see here. If you look at the blue line, the blue line gives you a value of about 70%, not 0%. All right. A normal kidney, normal proximal tubule will reabsorb 100% of glucose and amino acids. Please remember, it is not 70%, it is 100% of glucose and amino acids. So the best answer for this question is going to be sodium, right? Fine. Coming to question 10, 35-year-old woman had a sudden onset of hypertension, everything. Now you can clearly see that when her laboratory workup came back, it shows elevated levels of aldosterone and reduction in renin. I hope you are familiar with the way aldosterone is getting secreted from adrenal cortex. Please remember, adrenal cortex has got zona glomerulosa. And this zona glomerulosa of adrenal cortex is going to produce aldosterone, which is nothing but mineralocorticoid. The other two regions are zona fasciculata and zona reticularis. Fasciculata and reticularis is involved in synthesizing respectively cortisol as well as dehydroepiandrosterone. All right. Now for the zona fasciculata and reticularis, the trigger is going to be adrenocorticotropic hormone. For zona glomerulosa, the trigger is not ACTH. Rather, the trigger is going to be angiotensin 2, number one. Number two, hyperkalemia. Either there must be increased potassium or there must be angiotensin 2. It is these two substances that triggers glomerulosa to produce aldosterone. And you guys know angiotensin 2 comes from renin. So for normal aldosterone production, you require increased renin. That will increase angiotensin 2. That will increase aldosterone level. And what is the action of aldosterone in collecting duct of nephrons? Aldosterone increases sodium reabsorption. Aldosterone increases potassium secretion. Aldosterone increases hydrogen ion secretion. So if the pathway is very normal, you have to have more renin, more angiotensin, more aldosterone, and that's the way the action is getting manifested. This patient has got elevated levels of aldosterone in the presence of reduction in renin. So even though renin is reduced, aldosterone is getting overly synthesized. It means this patient is suffering through a condition called as Conn syndrome, which is nothing but primary hyperaldosteronism. This condition is Conn's syndrome, which is nothing but primary hyperaldosteronism. So what is going to be the manifestation in primary hyperaldosteronism or Conn syndrome? Too much of aldosterone. So there is going to be hypernatremia, hypokalemia, and metabolic alkalosis. So it is not acidosis. There is nothing to do with chloride. It will be hypokalemia. It has to be hypernatremia. So all four options you are seeing, the best answer is going to be hypokalemia, doctors. That's the right answer for the question. No, it's going to be hypokalemia. Coming to question 11. The nurse is measuring a parameter which is nothing but 5 liters of air. And she is also saying that it is a normal value. So what is the lung volume or lung capacity which has got a normal value of 5 liters? Which has got normal value of 5 liters? This is nothing but forced or vital capacity. So vital capacity is the one. It can be forced vital capacity or slow vital capacity, whatever it is. The normal value is going to be 5 liters. All right. So what is the question? Which statement below describes the correct capacity the nurse measured? All right. So first sentence was missing in the question. All right. I'm sorry for the typo error, doctors. The wrong option and the first sentence missing. I'm very sorry for that. But anyway, it's a learning experience. Now let's learn the question and let's learn the answer. No, it's nothing. It's just a training for you guys. Don't worry about it. Typo errors. So it's vital capacity. And when it comes to vital capacity, which answer fits appropriate for the vital capacity? All right. Amount of air that normally moves in and out with each respiration. This is nothing but tidal volume. Amount of air normally moves in, normally moves out. Tidal volume, and the volume is going to be 500 ml. So this is not the right answer. Option B, amount of air that enters the lung but does not participate in gas exchange. This represents dead space. And dead space volume is going to be 150 ml. Again, it is not indicating the right value given in the question. Option B is ruled out. The amount of air expired after maximal expiratory effort, amount of air that can be expired after maximal expiratory effort, seems to be forced vital capacity. So let's keep this option. Option D, largest amount of gas that can be moved into and out of the lungs in 1 minute. Largest amount of gas that can be moved into the lungs and out of the lungs in 1 minute. This represents minute ventilation. This represents minute ventilation, doctors. Again, this is not forced vital capacity. So answer C is going to be the best answer. Forced vital capacity is going to be 5 liters. That is the amount of air that can be expired with maximum expiratory effort after a full deep inspiration. That's option C, forced vital capacity, doctors. I hope you now get the right answer for the question 11. All right. I'm sorry for the first sentence missing. Anyway, at least you know now the right answer. I hope you could able to narrow down to the right answer, doctors. Now, if you see this question, I think you can able to understand one subtle point that this question makes. See, guys, you have already solved a question like this, where the exact direct answer will not be given in the option. The options will have an answer that is not perfectly matching the question or perfectly defining the question. But all three other options seems to be absurd and nonsense. So even though the answer is not exactly defining the question, you got to pick the answer as the correct answer because the other three options seems to be invalid or not very correlating with the question. All right. So even though you don't see the perfect textbook definition for the capacity here, if we see, considering all other options, option C seems to be the best fit for the question, doctors, which is why option 11 is question 11 has got C as the right answer. All right. So, yeah. Actually, seeing the single sentence during quiz, I thought only forced expiratory volume in first or second could be measured directly by spirometry. Is that right? No, Dr. Mohammed. There is a slight point you got to understand. When it comes to spirometry, what are all the parameters we can able to measure is? We can able to measure tidal volume. We can able to measure forced vital capacity, or we can able to measure slow vital capacity. We can able to measure inspiratory reserve volume, expiratory reserve volume, and as well as forced expiratory volume in first or second. These are all the parameters you can able to measure through spirometry. And what are the parameters that can't be measured by spirometry, for which you need other method called as nitrogen washout method, or you can use another method called as helium dilution method. Number 3, whole body plethysmograph. Whole body plethysmograph. All right. These three kind of techniques are used to measure, number one, residual volume. As a consequence of residual volume, functional residual capacity. Number three, total lung capacity. So spirometry is going to give you multiple parameters, not just FEV1, all right? So, there is a slight catch here, just be familiar. So it's not every, only FEV1, it's going to be all other parameters as well. So tidal volume is given as an option. And of course, with spirometry, since you can able to measure tidal volume, you can indirectly measure minute ventilation as well. That is also given an option. And what else is given an option here? So, yeah, thank you, Dr. Mohammed. Good, my pleasure. Dead space. Of course, we can't able to measure dead space. So option B can be ruled out. Simply looking at the question, you can ignore option B. But A, C, D can be an option possible with that one line itself. So make sure you understand this, that is all. So again, I'm sorry for the, typo part there. Question 12, a baby born prematurely is taken to the intensive care, everything. The ultimate question is, even though the question says a lot of history, the ultimate point is, the purpose of surfactant treatment is to, option A, help prevent alveolar collapse during breathing, seems to be right answer. So let's keep this as a check. Option B, stimulate AT1 cells to secrete natural surfactant in the alveolus. Please remember, surfactant treatment is not going to help in stimulating a cell, right? Even though if it is so, surfactants are synthesized by alveolar pneumocytes. Alveolar pneumocytes type 2 and not type 1, all right? So again, option B is wrong. Increase mucus lining, wrong. Stimulate innate immunity, wrong. And hence option A is the best answer for the question. Surfactant treatment is to prevent alveolar collapse and not for anything else. Question 13. A case of idiopathic pulmonary fibrosis. A case of idiopathic pulmonary fibrosis. It's a restrictive lung disease, doctors. It's a case of restrictive lung disease. What are all the parameters that tells you a clinical diagnosis is going to be restrictive lung disease, right? There must be a drop. Please remember, there must be a drop in total lung capacity. There must be a drop in residual volume. There must be a drop in functional residual capacity, a drop in forced vital capacity, a drop in forced expiratory volume in first second. Everything will be reduced, but there is going to be normal or sometimes increased parameters of FEV1 by FVC. All right, that's the hallmark feature of restrictive lung disease. And please remember, restrictive lung disease, the name itself tells you it is a restrictive disorder. It doesn't let the lung to expand completely. It is a restrictive disorder, and there must be a drop in compliance as well. There must be a drop in compliance as well. So all the options, a high FEV1, wrong. High FEV1, wrong. A normal FEV1, possible. High compliance, again, wrong. A low FEV1, right. Low lung compliance, right. So option D is the right answer for question number 13, doctors. Option D. I hope you get the correct answer here. Coming to question 14. Which of the following would be consistent with diagnosis of asthma? Now we are talking about the case of obstructive lung disease. Now, what are the characteristic features of obstructive lung disease, people? I think you can able to narrow down the conditions here. In obstructive lung disease, there is going to be normal total lung capacity, normal residual volume, normal functional residual capacity. Sometimes they may be even increased. And that is what is going to cause barrel-shaped chest. They are increased in barrel-shaped chest. On the other side, there is going to be a drop in forced expiratory volume in first second, a drop in forced vital capacity, and forced expiratory volume significantly drops. As a consequence, there is going to be drop in forced expiratory volume 1 by FVC ratio. There is going to be drop in FEV1 by FVC ratio, doctors, isn't it? So, and there is a method with which we elevate the bronchoconstriction. We administer patient with bronchodilators. Once the airway that was obstructed previously has been relieved by bronchodilators, you are going to find an improvement in these conditions. So initial test, by the first word itself, you can able to get to the diagnosis. Normal FEV1 wrong, normal FEV1 wrong, low FEV1 possible, low FVC possible, normal FEV1 to FVC wrong. So the best answer is you're going to have a low FEV1, low FVC, low FEV1 to FVC ratio. This is initial test. After inhalational treatment, everything seems to be normal, and D is the right answer for this question. So for question number 14, D is the right answer, doctors. For question 15, which of the following samples show poorest ability to hold on to oxygen? It's very simple. When it comes to oxygen in blood, 97% of oxygen is seen in combination with hemoglobin as oxyhemoglobin. Only 3% of oxygen is present in dissolved form. Doctors. So it is 97% that is going to be seen in combination with hemoglobin. So whenever there is going to be an absence of hemoglobin, it's going to significantly affect oxygenation of blood, and hence option B is the right answer. Which of the following sample shows poorest ability of all, right? So obviously it is going to be option B, because we just discussed 97% of oxygen combines with hemoglobin. Coming to question 16, a student is brought to campus and everything. A quick check of blood plasma shows increased bicarbonate. This itself will get you a diagnosis. It is going to be alkalosis. And plasma pH is also increased. This confirms your condition, alkalosis. All right. So more base, it is an alkalosis, which is proved by plasma. Is it respiratory or metabolic? If it is a respiratory alkalosis, what is going to be the picture? If it is a respiratory alkalosis, what is going to be the picture? We can have respiratory alkalosis in two different dimensions. One, it is going to be compensated respiratory alkalosis. Number two, it is going to be uncompensated respiratory alkalosis. In case of uncompensated respiratory alkalosis, there is going to be normal bicarbonate. In case of compensated respiratory alkalosis, you're going to see a drop in bicarbonate. This patient is going to have a bicarbonate level which is elevated, increase in bicarbonate. Definitely it is not a respiratory alkalosis, and the answer is going to be metabolic alkalosis. So that is option D, doctors. I hope, guys, you could able to identify this condition right. So please remember, how are you going to differentiate this from respiratory alkalosis is the gist behind the question. So I think you could able to understand what happens with compensation and uncompensated state. Question 17. How did the carbon monoxide affect oxygen transport in their blood? You know very well, when it comes to hemoglobin, we are going to find 4 different heme moiety. Each heme moiety is going to have ferrous in the center. All right, protoporphyrin ring has got ferrous, and there is going to be globin chain. So there is alpha globin chain, 2 alpha globin chain and 2 beta globin chain. That is what is going to contribute to hemoglobin, right? Now, these ferrous atom has got extreme affinity for oxygen, and carbon monoxide is going to straight away compete with this criteria. The site where oxygen binds to the ferrous atom is exactly competed by carbon monoxide. So oxygen is being taken off and carbon monoxide comes and binds with ferrous atom. So simply carbon monoxide competes with oxygen for hemoglobin, resulting in, even though hemoglobin is present, it is not going to be available for combining with oxygen. So it's going to cause a condition called as anemic hypoxia. Option C is the right answer for this question, doctors. So let's address the doubt as well. Compensated, please explain again. Okay. Now, when it comes to respiratory alkalosis, so let's understand how respiratory alkalosis is being formed at the first scenario. There is going to be hyperventilation of lungs. There is going to be hyperventilation of lungs. When lungs hyperventilates, there is going to be carbon dioxide washout. Without carbon dioxide, we are going to have impairment in one equation, that is carbon dioxide combining with water to form carbonic acid, H2CO3. Carbon dioxide combining with water to form carbonic acid, H2CO3, guys. Without carbon dioxide, you are not going to have carbonic acid. When there is no carbonic acid formation, it's going to be an alkalotic state, and that is exactly what is called as respiratory alkalosis. Now, where the problem is problem is with lungs, or the problem is with respiratory centers, which is exciting the lungs significantly. Now, how are you going to handle this problem? What body can do to overcome the ill effects of alkalosis? Now, this patient already has got enough amount of base. In another word, there is a balance between acid and base. Now, in respiratory alkalosis, the level of acid goes down. Even though the base level seems to be normal, it appears to be elevated. Now, the patient already has got relatively more bases, so you got to neutralize this base level. It is a problem of lung. So if it is a respiratory problem, who can come for compensation? Metabolic pathway should come for compensation, and metabolic pathway is nothing but kidney. So how come kidney compensates this problem? The patient already has got too much of bicarbonates. So kidney compensates this problem by eliminating more bicarbonates. By eliminating bicarbonate, kidney stops reabsorbing bicarbonates from proximal tubule, and kidney eliminates bicarbonate. This will lead to reduction in bicarbonate levels. So if you see a drop in bicarbonate level, this tells you it is a case of compensation. If it is not, it is a case of uncompensation. If kidney is not coming into the picture, the bicarbonate levels are going to be normal, or bicarbonate levels are going to be elevated, causing alkalosis, right? So that way we are going to find this picture, people. So excrete base more. Very good, very good. Dr. Pratish, you're absolutely right. There is going to be more excretion of bases, and this will lead to a drop in bicarbonate level. That's exactly what is called as compensation, right? So yeah. Oh, that's good. Fine. I hope now you got this picture clear, doctors. So let's move on to the next question. Yeah, question 18. Which of the following occurs if blood flow to alveolar unit in the region of perfusion ventilation defect is totally obstructed by pulmonary embolism? So let's get to see two conditions here, doctors. The first one is going to be a dead space, and the second one is going to be shunt. I want you to be clear of what a dead space is and what a shunt is. So let's take up two alveoli. In first alveoli, we are going to find a pulmonary capillary. In the second alveoli, there is going to be pulmonary capillary. Now, please understand what is meant by dead space and what is meant by shunt. Now, in first alveoli, what I'm doing is, consider there is an obstruction of airways or obstruction of alveoli. In the second alveoli, in the second unit, there is going to be obstruction of blood flow. Obstruction of blood flow. You got to be familiar with this word called gas exchange. You got to be familiar with this word called gas exchange. What do you mean by gas exchange? Take up a alveoli and take up a pulmonary capillary. There must be a transport of carbon dioxide from the capillary to the alveoli, and there must be a reciprocating movement of oxygen from the alveoli to the capillaries. So a movement of oxygen from the alveoli to the capillary and a corresponding movement of carbon dioxide from the capillary to the alveoli is what is called as gas exchange. Now, what do you mean by dead space? Dead space is a condition where you're not going to see any gas exchange. There is no gas exchange, doctors, and this is what is called as dead space. When I say no gas exchange, there is absolutely no gas exchange. This is exactly what is called as dead space. I hope you are now getting this one point clear. Now, let us get to see the first alveoli. In the first alveoli, what is happening? Since there is a blockade in the airways or alveoli, we are not going to find movement of carbon dioxide from the, we are not going to find movement of oxygen from the alveoli into the pulmonary capillary. This is not going to happen because there is no entry of oxygen in the alveoli. There is no oxygen entry. As a consequence, there is no oxygen transfer. But we are going to still see movement of carbon dioxide from the vasculature into the alveoli. Part of gas exchange is still happening. Can you call this as dead space? No. So this is nothing but a hypooxygenated alveoli. This is nothing but hypooxygenated alveoli, or there is not going to be any oxygen into the alveoli. So this represents alveolar hypoxia. Represents alveolar hypoxia. One of a crucial point you need to understand here in this question is, when there is hypoxia everywhere in body, when there is hypoxia everywhere in body, brain, heart, liver, muscles, skin, wherever you take up, if oxygen level to a tissue is getting lesser and lesser, the vasculature for that tissue gets dilated. So everywhere in body, hypoxia will cause vasodilatation. This is a very important point you have to remember. All throughout the body, hypoxia is going to cause vasodilatation. And there is a one exception called lungs. In lungs alone, whenever there is going to be hypoxia, instead of causing vasodilatation, lungs will cause pulmonary vasoconstriction. So this is one unique feature of organ blood flow. People, please remember, in pulmonary circulation, wherever there is going to be alveolar hypoxia, instead of vasodilatation, there is going to be vasoconstriction. So what will this do to a alveoli? Consider this is alveoli number 1, alveoli number 2, and alveoli number 3. In normal scenario, we do have a pulmonary capillaries like this. Wherever there is going to be alveolar hypoxia, since if there is a blockage of alveoli, the blood vessel going to that particular alveoli will be completely collapsed. It will be completely collapsed, and the blood that is supposed to go into the first pulmonary capillary will go to the second pulmonary capillary. There is going to be reciprocating relaxation of neighboring pulmonary capillaries. More blood will go into those regions. This shunting of blood from the closed alveoli to a well-ventilated alveoli, this condition is called as shunt. Please remember, this is not a dead space. This is called as shunt. All right, people. So let me be clear here. When it comes to the first alveoli, you're going to see blockade of alveoli. This condition is called as shunt, doctors. This is not dead space. When you consider the second example here, you're seeing a vasculature completely getting occluded. It may be a thrombus or thromboembolism or complete severe right heart failure where there is no cardiac output from the right ventricle into the lungs, or severe massive pulmonary stenosis, no blood is getting into the pulmonary arteries and capillaries. In these conditions, there is no blood flow. There is no blood flow into the blood vessel. As a consequence, the blood vessel itself will become collapsed. When the blood vessel itself is collapsed, there is no blood flow. Here, you are not going to see carbon dioxide transport. You are not going to see oxygen transport. Now there is going to be complete cessation of gas exchange. This condition is called as dead space. This condition is called as dead space. So please understand, in this condition, in shunting, what is the problem? There is going to be ventilation perfusion ratio. There is going to be normal perfusion and zero ventilation. In dead space, there is going to be, when it comes to ventilation perfusion ratio, there is going to be normal ventilation and zero perfusion, doctors. That's the scenario between dead space as well as shunting. Now, when it comes to the values, if you take up 0 as the numerator and the denominator is normal, you are not going to find any meaningful value. So V/Q ratio in shunt is going to be 0. V by Q ratio in dead space is going to become infinite because you are going to divide ventilation by 0 and you're going to get a value infinite. All right, people, that's dead space as well as shunt. Be clear here. Now, this question, which of the following occurs if blood flow to the alveolar unit in the region of perfusion defect is totally obstructed by a pulmonary embolism? What is getting formed? Is it dead space or is it shunt? You are going to develop a condition called as dead spaces. Now, what are the options in the question? Option A, there will be a reduced arterial PO2 due to venous arterial shunting. There will be reduced arterial PO2 due to venous arterial shunt. No, this is not a shunt, doctors. This is not at all shunt. The PO2 of affected alveoli by the embolism will be equal to PO2 in the inspired air. There is a possibility of having this question right. Question C, the anatomical dead space is decreased. Again, this is wrong. I hope you know what is an anatomical dead space. Anatomical dead space is a region where there is not going to be gas exchange by the nature of anatomical structures itself. If you consider the airways, starting from trachea all the way to principal bronchus and bronchioles, these three proximal airways have got no connection with alveoli. As a consequence, there is no gas exchange. Hence, the volume of air existing between trachea all the way to bronchiole. All right. This space is called as anatomical dead space. This space is called as anatomical dead space, which is very normal, present in every single lung. When a blood vessel is getting blocked, and as a consequence, if there is a dead space creation, this dead space is called as alveolar dead space. So you need to be familiar with the difference between anatomical dead space and alveolar dead space, doctors. Anatomical dead space is something which is always present. Alveolar dead space is something which will occur whenever there is a thromboembolism occluding pulmonary capillaries. Right? So that's anatomical dead space and alveolar dead space. In case of dead space increased by pulmonary embolism, what kind of dead space is increased? It is going to be alveolar dead space and not anatomical dead space. Hence, option C is wrong. Anatomical dead space is decreased. There is not going to be any change in anatomical dead space. Then, option D, ventilation perfusion of the alveoli in the affected area goes to 0. That is again wrong, doctors, because when it comes to ventilation perfusion ratio, you have to have infinite value for dead spaces and it is not going to be 0. So it is going to be the option B. It is going to be option B, the right answer for this question. People remember this. This is an exact question that has been asked in previous year INICET paper, ventilation perfusion ratio. Now, the option B is something that we got it from the previous year question papers and previous year candidates who went and took up the exam and gave this option. There is a slight catch here. The PO2 of alveoli affected by embolism will be equal to PO2 in inspired air. This needs to be understood a little bit. The point here is, even though this is the best option for the question, it is not exactly right. We'll see what happens. When it comes to total atmospheric pressure, it's going to be 760 millimeters of mercury. We refer this as 1 ATM, standing for 1 atmospheric pressure. This is total atmospheric pressure, which is contributed by multiple gases, oxygen, nitrogen, inert gases, everything. Out of the 760 millimeters of mercury, the nitrogen contributes to 70%, oxygen contributes to 21%, inert gases, helium, argon, boron, krypton, they contribute to on an average of 9%. Carbon dioxide contributes to 0.003%. This 21% of oxygen is going to give a value of 149 millimeters of mercury. Simply speaking, 21% of 760 millimeters of mercury roughly translates to 149 millimeters of mercury, people. This is the exact value of the partial pressure of oxygen in the atmosphere, which is nothing but inspired air. Now, when we are inspiring, what happens is, when this air gets into the airways, starting from nose all the way to pharynx, all the way to larynx, and airways, trachea onwards. The epithelium of nose, pharynx, and larynx, what does this epithelium do is, they keep on humidify this incoming air. The epithelial cells add water vapor. Water vapor is also a gas, doctors. This water vapor is added by the epithelial cells at a partial pressure of 47 millimeters of mercury. As a consequence, when the air reaches alveoli, when the air from the atmosphere reaches alveoli, the partial pressure of oxygen is going to be diluted by water vapor coming and diluting the oxygen. So when the incoming air is going to be mixed